Quiero agradecer enormemente al doctor Roger McIntyre por la generosidad que ha tenido con nosotros, con la asociación, de tener esta conferencia para todos los psiquiatras de Argentina. Obviamente el profesor McIntyre no necesita presentación, todos lo conocemos. Es profesor de la Universidad de Toronto, ha escrito más de 400 papers, pero quizá lo que no muchos saben y que me gustaría remarcar es que fue nombrado por Clarivate Analytics como una de las mentes científicas más influyentes del mundo en 2014, 2015, 2016 y 2017, porque sus trabajos han llegado a un amplio campo de las ciencias y de las ciencias sociales, lo cual habla de la figura importante que es el profesor McIntyre y que tenemos hoy el placer de disfrutar de su charla. Roger, muchas gracias por estar con nosotros.
Well, thank you for having me. Thank you for inviting me, and greetings from Toronto, Canada. It's been quite a few years since I've had the opportunity to be in Argentina, and I've had wonderful visits in Argentina with some very good friends and colleagues. This has been a very difficult time with COVID-19 pandemic. We all know this has increased the rate of depression around the world. It's also, in fact, a time of further concern because people who have depression, according to some recent data that we have published, are at greater risk of contracting COVID-19 and having complications from COVID-19. So these are certainly very challenging times, and today's topic is a challenging condition, that being treatment of depression, especially when the initial treatments are not successful. We're going to have lots of time for dialogue and questions on this topic. This is a disclosure of organizations that I work with in the public and private sector. This is, in fact, an attempt to provide some learning objectives. We're going to define what we mean by treatment-resistant depression or difficult to treat depression. We're going to talk about some factors that are associated with this, and I want to spend some time discussing some of the new treatments that we have now that we're using in different parts of the world. Now, we know that depression is common. For many people, it is lifelong. We all know it's debilitating and costly. And when we look at populations of adults with depression, about 20 to 40% of patients do not actually enjoy symptomatic improvement. In these patients, which have been variably defined as so-called TRD or difficult to treat depression, are overrepresented in the economic costs, the healthcare service utilization costs, and the requirements for disability and unemployment benefits. And everybody knows that. So we're talking about not only a common subpopulation, but it's a population that is disproportionately accounting for the costs that are related to depression. Now, before we get into how common or how to define or how to treat treatment-resistant depression, it's a good idea to start off with what are, in fact, the therapeutic objectives in depression. Now, when I started as a psychiatrist, the objectives therapeutically were to achieve a response. That objective was refined further to achieve full symptomatic remission. In the last 5 to 7 years, there's been a further refinement to include functional recovery. And what's interesting is that when you ask people who live with depression, as well as ask their doctors, what are the priority therapeutic objectives in depression, we get different reports. We get different feedback. Clinicians put more of a priority on alleviating symptoms. Patients put more of a priority on achieving positive mental health. And too often, patients, even when they're in remission, do not experience positive mental health. They don't feel a sense of hope, a sense of independence, a sense of empowerment or engagement, and they certainly don't feel a sense of vitality in their day-to-day lives. Historically, when we talk about the definition of treatment-resistant depression, the definition that many regulators around the world use, notably the US FDA, is failure to adequately respond to 2 or more trials of different antidepressants from different classes. And we know that there are different schemas. There are approximately a dozen definitions of treatment-resistant depression, but the definition of suboptimal response to 2 or more antidepressants is in fact the most often employed definition. Now, the reason in part we use the definition of 2 or more antidepressants being a definition of treatment-resistant depression is based on clinical experience, based on clinical trial results, and also based on effectiveness results. For example, the results from the STAR-D trial. And results from STAR-D trial indicated that the majority of people who are prescribed a conventional antidepressant do not achieve remission with the first-line treatment. In fact, it's only about a third. And then with the second-line treatment in the orange, only another third achieve remission. And then see what happens with the third-line treatment, only 14% achieving remission. So this observation of attenuated remission rates as a function of treatment steps, as well as decreased quality of life and functional recovery as a function of treatment steps, has been a highly replicated finding. And going back to the point I made a moment ago, that patients and doctors have very different definitions of what they prioritize with treatment, we also have very different understandings of what remission means. In fact, when we use a clinician outcome assessment, like the Hamilton Depression Scale, the definition of remission, the so-called MacArthur definition, using the HAM-D17, is a score less than or equal to 7. When patients with depression are treated with conventional antidepressants and they are in remission, according to that definition, half of them still, in fact, do not feel they're in remission. And this tells me that there's other aspects of their depression experience that we are not sufficiently improving. In a few moments, I'm going to talk about cognition. I'm going to talk about anhedonia. May say a few words about emotional blunting. Notice that during the last 3 to 4 decades, overall, antidepressant rates, response rates have not significantly improved. Overall, placebo response rates are getting better. This is in part because treatment trials in depression are increasingly being conducted in outpatients rather than inpatients. Secondly, you see, in fact, large numbers of patients coming into clinical trials, introducing heterogeneity. And you also have, in fact, in many cases, antidepressants being studied in centers, in fact, that are not, in of themselves, experts in the area of mood disorders or drug psychopharmacology. And I think, in fact, when it comes to what should you and I be doing in people who are not benefiting from a conventional antidepressant, well, we need to check the diagnosis. I always begin with looking for psychiatric comorbidities, and there's many that we know about. I also look for physical comorbidities. Of course, thyroid is the one that everybody knows. But also don't want to forget that obesity and type 2 diabetes, which have a rate in depression almost twofold greater than the general population, are known to be associated with an attenuated response to antidepressants. It's also important that we rule out bipolar disorder. For reasons we're not fully understanding, people with bipolar disorder do not have as robust or as predictable a response to antidepressants as do people who have major depression. Screening for bipolar disorder, you all know the mood disorder questionnaire, the hypomania checklist 32. Good screening tools, they're brief, patient administered, they've got good sensitivity and good negative predictive value. In other words, if someone screens negative, you're confident they don't have bipolar. But these screening tools also, in some cases, can have false positives. What we try to do is create a new screening tool called the Rapid Mood Screener to screen for bipolar. It doesn't diagnose bipolar 1 disorder, it only screens for it. And a couple of points I want to just put a fine point on is that this is a briefer scale, 6 items. It also asks about age at onset before age 18, your response to conventional antidepressants. And we think these questions have reduced some of the false positives that we sometimes see with, in fact, screening tools. Now, I know that we have a Spanish-speaking population. This was validated in English. It's free of charge. Just go to that particular article. You can get it free. But we are looking at validating it in different languages. We know that people with depression, with a history of childhood maltreatment, have a very different depression. We know that the phenomenology overlaps with, but is different than depression without trauma. And underlying neurobiology is different. For example, they're more likely to have elevation of inflammatory markers. A replicated observation has been that people with depression in adult age who report childhood maltreatment, that is before the age of 7, have an attenuated response to SSRI therapy. And every mental health care provider knows that because they see it clinically. This, for me, indicates that depression with trauma is a different biophenotype than depression without trauma. It also means that for patients with trauma who are not benefiting from antidepressants, we will need to think about mechanistically very different approaches to give these persons a better chance for success. I mentioned a moment ago that obesity and overweight are more common in depression. We know that obesity is not just common in depression, but it's associated with cognitive impairment as well as attenuated antidepressant responses. Interestingly, when people lose weight through, for example, bariatric surgery, there's significant improvements in their cognition and their reward function. So taken together, there are factors that are moderating antidepressant response, notably childhood maltreatment, but also other factors that in some cases are modifiable, like obesity, which is known to affect brain structure and brain function and known to moderate antidepressant response. Every guideline that's been published, there's over 150 to 200 guidelines in depression around the world, agrees that we need to improve functional outcomes in depression. One of the treatment decision points that has changed in the last 15 years is the recommendation to optimize dosing at 2 to 4 weeks rather than 6 to 8 weeks. When I began my career as a psychiatrist, we optimized the antidepressant at 6 to 8 weeks. Now we start an antidepressant, and if after 2 to 4 weeks a patient is not benefiting, that is, they don't exhibit at least a 20% or greater improvement, then that's the indication to optimize the dose. We also know that people who have depression have very common residual symptoms. Residual symptoms can often lead to subsequent relapse and recurrence. The most common residual symptoms that we see are sleep disturbance, fatigue, cognitive impairment, and anhedonia. And these types of symptoms are debilitating to people who have depression. This is why it's common to not only see people who do not have a significant improvement, but also to see people who have residual symptoms. Today, in fact, I was speaking to a patient who started an SSRI and had emotional blunting from the SSRI. Anhedonia is the absence of experiencing pleasure or anticipating pleasure. Emotional blunting is a constriction, a narrowing of your affect. People with emotional blunting often feel detached or disconnected. And we know that emotional blunting is part of depression. In fact, people with greater severity depression are more likely to have emotional blunting. But we also know that emotional blunting is a side effect of many SSRI antidepressants. In patients who have depression, who rate their antidepressants as suboptimal, very often report blunting and anhedonia. A very interesting question is whether we should pay with money our patients to take their medications. I don't think we should pay them to take their medications, but I want to show you a result from a clinical trial published earlier this year that really caught my eye. What investigators did was they randomized patients with depression to a control group, just take your antidepressants as recommended, or to a payment group. They got paid. And that was called the escalating and de-escalating groups. What they found was people who were paid were more likely to take their antidepressants. That's what they're paid for. And people were paid in two different schemes. Escalating group, they got paid $2 a day the first week, $3 the second week a day, $4 a day the third week, and each week up until week 8. The other group, the de-escalation group, got $8 a day the first week, $7 a day the second week, and so on and so on. In terms of the escalation group, did better with 90.7% adherence versus 83.4% in de-escalation, which was clearly better than not paying patients. My point is not to pay the patients. My point is people with depression have a fundamental deficit in what's called reward learning, because both groups that were paid got paid the same amount. But clearly the group that was escalating did better, in part because the reward process is abnormal in depression, the reward learning. So we need to anticipate not just the absence of pleasure, the lack of experience of pleasure, but deficits in reward learning that lead to non-adherence. About 50% of patients who take SSRIs or SNRIs have emotional blunting. Again, this is also part of depression, but it's also a side effect of the medication. At the start of the meeting, I said that COVID-19 increases not just the risk for depression in the sense of the stress, but it also, in fact, has been shown that people who have depression are at greater risk of contracting COVID-19. What's also been observed, perhaps because of the chronic stress, is that anhedonia has been exacerbated during this time. And I think people know people are complaining about fatigue and difficulties in their day-to-day lives. Let's talk about how we can further improve outcomes in depression. Benzodiazepines can worsen cognition. They can worsen anhedonia. What's interesting in an analysis that I did is that male prescribers are more likely to give female patients benzodiazepines than are female prescribers. That's not the point of today's presentation, but I thought that was interesting. And what's also interesting is that if you take benzos, you're also more likely to have anhedonia. Here's a separate analysis. These data show that the greater your anhedonia severity is, that is, the greater your score on the x-axis, the less likely SSRIs will work. This is why I often will use vortioxetine or an SNRI like desvenlafaxine, especially in patients with cognitive impairment, fatigue, apathy, and certainly patients with anhedonia. Taken together, disturbances in cognition as well as disturbances in reward account for approximately 2/3 of the overall impairment in depression. This is why psychiatrists so often see patients with debilitating symptoms of anhedonia, fatigue, cognitive impairment, and blunting, and why patients are so dissatisfied with treatment. Other lines of research show that anhedonia, if it improves, accounts for a significant degree of improvement in patients' overall psychosocial functioning. The improvement in anhedonia as a mediator of overall function exists alongside other lines of research that improving cognition function in depression has been shown to improve overall psychosocial function and workplace performance. So taken together, cognition and anhedonia are critical therapeutic targets. Now, here in Canada, we prescribe conventional antipsychotics. These are the second generation antipsychotics like brexpiprazole, aripiprazole. We don't prescribe as much quetiapine as we used to because of sedation and weight gain and diabetes. And there's no question that dopamine partial agonists like brexpiprazole can be very helpful in treating depression in adults who have not had an optimal response to antidepressants. Moreover, atypicals can treat rumination, anxiety, agitation, and mixed features, which are also very common in treatment-resistant depression. They do, however, have side effects, and this is one of the limitations of that class of medications. So the benefits of atypical antipsychotics is that they have a robust evidence base, at least some of them do. They increase response and remission, especially commonly encountered symptoms like anxious distress, mixed features, agitation, and rumination. But that does then mean that there's more polypharmacy. There's a risk of weight gain and metabolic shift. It depends on the actual agent, as well as extrapyramidal side effects in tardive dyskinesia. I can't think of a more exciting time to be in psychiatry. There's so many new targets that are being looked at as potential for patients with depression. For 7 decades, we have focused exclusively on monoamine drugs. We've now expanded into different areas. Let's talk a little bit about ketamine. So ketamine was synthesized in 1962 in northern Michigan. Ketamine was approved in 1970 by the US FDA as an anesthetic. In addition to being an anesthetic, ketamine is also an analgesic, anti-inflammatory, and an antidepressant. Ketamine and its isomer S-ketamine have demonstrated efficacy in the treatment of adults with treatment-resistant depression. Ketamine and S-ketamine represent 2 glutamate-based drugs. This is a very different target than serotonin or norepinephrine. And this slide is only to give you an idea of how many different drugs are being developed that have effects on the glutamate receptors. There's quite a few receptors, 3 ionotropic receptors, they're ion channel based, and 8 what's called metabotropic receptors. So you can see that the field of psychiatry is developing many new treatments that target glutamate. In May of this year, in the American Journal of Psychiatry, we published the international guidance on the implementation of ketamine and S-ketamine in adults with depression. I would strongly encourage you to download a copy of the article. It synthesizes the literature, summarizes the science, and also gives guidance on how to select the appropriate patients, what's the appropriate personnel and setting, and what's the appropriate way to administer and monitor ketamine and its treatment. For those who may be less familiar, the data are robust for intravenous and intranasal ketamine. We have less data for other routes of delivery or other formulations of ketamine. We also, in fact, have long-term data for S-ketamine out to 1 year, which is longer than we have for any other drugs in treatment-resistant depression. At my centers in Toronto, over 98%, 99% of the patients receive IV racemic ketamine. Some interesting questions we still need to address. What's more effective, the IV ketamine or ECT? Or what's more effective, IV ketamine or a second-generation antipsychotic? There are some data, that is meta-analytic data, that suggests that ketamine might be superior to second-generation antipsychotics. A third question is, what's better, IV ketamine or S-ketamine? This is a meta-analysis that I published. We still don't have the final verdict, but we do have some data to suggest that there are advantages to both products. Depends on which day we're actually looking at, day 1, day 7, or for that matter, day 28. In addition to improving depression, ketamine also decreases suicidal thinking. And we have just been given a grant by the Canadian government to integrate ketamine IV racemic with cognitive behavioral therapy delivered virtually to reduce suicidality. For now, the only drug that is FDA recognized as anti-suicide is clozapine. There are observational data, largely, for lithium reducing suicide, but this is clearly an area we need to improve. Another question which needs to be addressed scientifically is what's the best way to prolong the efficacy of ketamine? For now, it's giving the drug repeatedly over time. But we're also interested in whether transitioning patients to psychotherapy, like CBT, could prolong the effects of ketamine in people who take this particular treatment. Now, when S-ketamine was studied in treatment-resistant depression, it was combined with a newly initiated antidepressant. For example, an SSRI like escitalopram or sertraline, or an SNRI like venlafaxine or duloxetine. And these are patients who started a new SSRI or new SNRI plus placebo, or an antidepressant plus Spravato or S-ketamine. And results demonstrated superiority of S-ketamine at day 28, but also at day 24. So this represents a separate delivery, intranasal, and it's the isomer, the S-ketamine isomer. Along with offering acute symptomatic relief, S-ketamine also demonstrates recurrence prevention effects in people with treatment-resistant depression. Now, I've had an interest throughout my career in the role of inflammation in the cause of depression, as well as its phenomenology, its comorbidity, as well as response to treatment. Begs the question, are anti-inflammatory drugs antidepressant? Well, we don't know. We do have some data for NSAIDs, omega-3, especially eicosapentaenoic acid, EPA, especially in people who have elevated CRP protein. Some data for statins and minocyclines. I know all of you are familiar with this data. It was published a year ago, more than a year ago, showing that fluvoxamine can reduce decompensation from COVID by targeting the sigma-1 receptor. The sigma-1 receptor communicates with the endoplasmic reticulum, reducing inflammation. This has now been replicated in Lancet Global 6 weeks ago in Brazil, a large study, 1,600 patients, showing that fluvoxamine can decrease decompensation from COVID. This tells us indirectly that our conventional treatments, like an SSRI, have effects on the immune system. My team in Toronto has been studying the antimicrobial drug, minocycline, a relative of tetracycline, as a potential antidepressant, along with being a drug that stabilizes microglia, which are the macrophages in the central nervous system. Minocycline is also anti-inflammatory, and we have some data, albeit experimental, investigational, that it can improve depression. I'm not aware of whether or not the orexin antagonists are available in Argentina. There is, in fact, a physiology around orexins. Orexins are produced in the lateral hypothalamus. There are two orexin receptors, the orexin A and B receptors, and the orexin receptors participate in arousal. People who have sleep disorders often have a problem with arousal, and there are what's called single orexin receptor antagonists, and there are dual orexin receptor antagonists, SORA and DORA. And what we know is that these orexins are not only relevant to arousal and sleep, but also relevant to mood and cognition. And there's now interest in developing these drugs as antidepressants. So here in Toronto, we're interested in looking at some of these drugs like lamborexin and suvorexin as potential antidepressants. Here's another one called seltorexin. Again, just to let you know, there's very different targets, and this is targeting a peptide relevant to sleep in chronobiology. Many of you have been hearing about psilocybin. I'll get you to mute your lines if you could. Yeah, if you just mute your lines, that would be great. Now, psilocybin is a psychedelic. It was discovered by Albert Hofmann, who's the same person who discovered LSD. He discovered psilocybin about 15 years after he discovered LSD, working for a pharmaceutical company in Switzerland. And many would know that psilocybin was, in fact, widely considered a treatment for adults who had mental illness. There are over 24 small companies that are looking at psilocybin. Just this weekend, we started Canada's first ever randomized trial with a repeat dose psilocybin in adults with treatment-resistant depression. There are some preliminary data that psilocybin might be able to attenuate depressive symptoms in adults with depression. We don't know yet if that's true, but it's preliminary, and we look forward to the results of our clinical study. In Argentina, you have bupropion. If I remember correctly, you also have dextromethorphan. Dextromethorphan is a drug that was developed for reducing cough, but it was also developed for other reasons. It affects the glutamate system. A combination pill called AXX05 is the combination of dextromethorphan and bupropion. Bupropion affects norepinephrine and dopamine. Dextromethorphan affects the sigma-1 system, the glutamate system, the opioid system, as well as the serotonin system. By combining bupropion with dextromethorphan, you increase the bioavailability of dextromethorphan. And this combination of dextromethorphan and bupropion has been shown to be more effective than bupropion alone. And this is interesting because this is combining monoamines with glutamate. This drug is under review by the FDA. Just to let you know, everybody knows methadone. Methadone is available to help patients with opioid use disorders. Dextromethadone is also a glutamate drug, and it's been developed now as a potential antidepressant. I put that in there for your interest. For patients with depression not responding to any antidepressant, we have to think about ECT, which is still the most effective neurostimulation in TRD. We also have data for rTMS as effective in treatment-resistant depression, although the effect sizes are greater for ECT than they are for TMS. What about psychotherapy? We don't really have good evidence that cognitive behavioral therapy or interpersonal therapy are effective alone in the treatment of adults with treatment-resistant depression. The data suggests combining with antidepressants is best. In this analysis, which I really enjoyed, identified 5 symptoms in depression that are more responsive to antidepressants than is CBT. And those symptoms are depressed mood, feeling guilty, thoughts of suicide, psychic anxiety, and feeling tired, so-called general somatic symptoms. In other words, anhedonia in cognitive-related symptoms do better with antidepressants than psychotherapy. That's why it makes good sense to combine these treatments together. The COVID-19 pandemic has only amplified the worldwide difficulties with loneliness. Loneliness is a serious problem associated with higher rates of depression, anxiety, suicidality, obesity, diabetes, and heart disease. The hazards to your health of being lonely are similar to smoking a pack of cigarettes a day. Along with providing medication and psychotherapy, it's incumbent upon us to also address the interpersonal world that the person lives in, to boost resiliencies and to decrease the risk. And there are some data to show that very simple programs delivered by lay people that are empathy focused can reduce some of the hazards of loneliness in people who have depression. So this is an area that we also should be looking at as we're trying to help patients, especially during this COVID time. As I said, psychotherapy on its own in treatment-resistant depression, not shown to be effective, but combining it with antidepressants does seem to be effective and should be considered as an adjunct to other antidepressants in patients who are not benefiting sufficiently. I asked the question out loud earlier, what's more effective, NMDA drugs like ketamine or antipsychotics? We don't know. We never had a head-to-head trial. But there's some preliminary data suggesting that the glutamate drugs may work faster and may in some cases have a greater effect size. We clearly need more work. So treatment-resistant depression is certainly very, very common. What we also know is that treatment-resistant depression, not just common, but is a condition characterized by profound anhedonia and cognitive impairment. Let's screen for diagnosis, make sure it's accurate, target comorbidities, make sure the patient and yourself agree on the therapeutic objectives, make sure the patient's taking their medication, and let's make sure we're providing sequentially medications and psychotherapy as indicated and where appropriate to give neurostimulation. So I want to leave lots of time for any questions or comments you may have. The floor is now open.
Bueno, muchísimas gracias, Roger. Un placer enorme que estés con nosotros. Y yo en principio quería hacerte una pregunta. La semana pasada el ANMAT, que es la Administración Nacional de Medicamentos en Argentina, aprobó el Rexulti, el brexpiprazol, como tratamiento coadyuvante para el trastorno depresivo mayor en adultos, porque en Argentina solo estaba aprobado como antipsicótico. Y bueno, como en Canadá ya hace rato que está esto, quería saber tu experiencia.
Yeah, my experience with Rexulti, brexpiprazole, in people who have depression has been very positive. I find it to be well tolerated. I find it to be safe. I also find it to be very effective. And where it's especially effective is in treating not just depression, but also treating anxiety, as well as treating It's treating anhedonia, it's treating agitation, it's treating mixed features and anxious features. So in other words, I find it to be very effective. The dose that I use is 0.5 milligrams to start, and then I increase the dose to 1 to 3 milligrams as tolerated. Most patients that I see are taking doses of 1 to 2 milligrams. I'm really pleased to hear that you now have the medication in Argentina. I think you'll have a positive experience with it. I should also emphasize that with respect to Rexulti, that the risk of akathisia is a lot lower than the risk that we see with aripiprazole, and it seems also to have a lower risk of weight gain. So that's something I think is really, really, really interesting and something we should take into consideration. So overall, I think you're going to be very happy with it. I certainly have been, and I tend to use relatively low doses of the medication, but really glad that that you have that medication now.
Otra pregunta, ¿qué antidepresivo usted recomienda después de la administración de esketamina?
Well, I think that if a patient is not responding to S-ketamine, we might just give them IV racemic ketamine. Do you have S-ketamine available now in Argentina? Yes?
Sí.
Yeah. So what I would do if they don't...
Son trabajos de investigación actualmente.
Right, okay. I would say if they don't benefit from the escitalopram, we tend to give them IV ketamine. So intravenous racemic is what we would give them if they don't benefit from the S-ketamine, or we will give them ECT or TMS. So ECT or TMS, or what we will do is we will give them IV racemic ketamine.
Aquí hay una pregunta, ¿qué opinión le merecen los resultados de la estimulación cerebral profunda del área 25 para depresión refractaria?
You know, we had hoped that deep brain stimulation was going to be effective in depression. Some of that work on deep brain stimulation was done here in Toronto at my hospital. Unfortunately, what happened is that for deep brain stimulation, the early results looked very, very promising, but unfortunately the controlled trial results were very, very disappointing. So taken together, we don't have good evidence right now in rigorous studies that individuals with treatment-resistant depression can expect to benefit from deep brain stimulation. So unfortunately, it's been quite disappointing.
Aquí hay otra pregunta. ¿Han podido valorar dosajes de serotonina plaquetaria y cortisol matutino y vespertino? Valorar dosajes de serotonina plaquetaria y cortisol matutino y vespertino.
You know, I don't measure any of the biomarkers that you mentioned, like platelets or serotonin or cortisol. We also don't measure inflammatory markers. There's no biomarkers that we're measuring right now. I think that in the future of psychiatry, it is quite possible that we might be measuring other biomarkers in the future. But for now, there's no biomarkers that we do. Also, what's very popular here in North America is doing genetic testing. We don't do routine genetic testing of cytochrome P450 as an example, or some of the pharmacodynamic targets. We don't, in fact, do those as a routine. In some people, we might do those if they're having significant problems with drug-drug interactions or tolerating medication. So no, we don't check platelet serotonin or cortisol, or for that matter, other biomarkers. For now, it is a clinical impression by seeing the patient.
Y el doctor Lamezón y el doctor Corral nos acercan que sí está disponible el Spravato.
What was that again, sorry?
Spravato, en Argentina.
Oh, Spravato? Yeah.
Yeah.
Yeah. Okay, that's good to know that, actually. I didn't know it was available there.
Uh-huh. Uh-huh.
That's good to know that.
Uh-huh. Y bueno, hay muchísimas felicitaciones. Yo realmente creo, como usted decía, que es un momento muy especial para la psiquiatría, para identificar nuevas dianas moleculares, ¿no? Digamos, después de 70 años, como usted nos dijo, estamos en un momento brillante para la psiquiatría.
Yes, it sure is. It's an exciting time.
¿Cuáles han hecho investigaciones sobre el MC-TOR? Usted lo presentó en una de sus diapositivas.
Which one?
MC-TOR.
Oh, yeah. So mTOR is the mammalian target of rapamycin, and it is upregulated by ketamine. And it's interesting because along with enhancing BDNF, it's also observed that ketamine increases mTOR, and that might play a role in neurogenesis and plasticity. So that's one of the mechanisms of ketamine.
Así es. Bueno, yo ya quiero liberarlo, agradecerle enormemente su generosidad, otra vez vuelvo a decirle, esto ha sido un lujo para todos nosotros los psiquiatras en Argentina, para la Asociación Argentina de Psiquiatras, para el capítulo de Psiquiatría Biológica, que bueno, estamos finalizando el año con el placer de su conferencia. Realmente muchísimas gracias, Roger.
Oh, thanks for having me. Keep good health, and I hope in 2022 we'll be able to be together in person. So thank you for inviting me.
Ojalá. Así sea. Bye.
Absolutely. Take good care. Bye-bye. Nice seeing you.
Take care, dear.
Bye-bye.